last thing, any questions you have, feel free to submit questions in the chat. And Jessica and I, and also Debbie, who will come on later, who's our second MC, will be monitoring the questions and forwarding them to our presenters today and speakers. Okay, so ready to go? All right, now we're streaming live on Facebook. Welcome everyone to our teach-in today. I'm really happy to see everyone here. If you are here to learn what to do and how you can stop discriminatory care practices in hospitals, if you're here to learn about people who are affected by these discriminatory care rationing practices in hospitals, you're in the right place. We're excited to have you here and to also take some action with you throughout the teaching today. So we walked through a few Zoom steps earlier before we started streaming, but if you have any questions, again, feel free to message us in the chat. We'll try to answer them as promptly as possible. Any access needs come up during the session, also feel free to comment on Facebook Live or put it in the chat today on our Zoom meeting. So before I introduce our speakers, just want to give a quick introduction to our topic today. Just a basic overview of the problem that we are in since the beginning of COVID and also before, of course. So in early June, after months of fighting for better care, we got new guidelines in the state of California. The previous guidelines of California state were following the examples from Italy and New York, which allowed hospitals to make decisions on who lives and who dies based on their perceived worth of a person's life after survival. So that meant people were making decisions on whose life was worth saving and whose wasn't. And this is a question that should not exist, right? The power of responsibility in making that decision should not be on the shoulders of doctors and nurses fighting the virus. And currently we're seeing the climb of COVID cases across California, but also throughout the country. It's been a steady climb, right? And these rises in numbers echo the first outbreaks that we had long time ago in March. And nursing homes and other congregate living facilities, such as long-term care facilities or single room occupancy hotels, but also detention centers and jails and prisons, right, have never stopped being COVID ticking bombs. And now more than ever, we need to be aware of how our local facilities are adhering to the state guidelines, as well as the guidelines that that people have been promoting throughout the United States, this is an issue of ableism, which is the belief that disabled people aren't worth as much as non-disabled people. And it is also an issue of ageism that believes in certain age group is not worth as much as the other age group. In this case, older people are not worth as much as younger people. And is also an issue of racism. Because as we see, the centuries of this country's racism is reflected in who dies during COVID, with higher chances of illnesses and shorter lifespan in African American, but also immigrant communities, really show who amongst older and disabled people is not going to be chosen to save. So with this issue, I hope to present us with goals for today, which is educate people about care rationing and why it's critical. 2, raise public awareness about this issue. Everyone who's here today needs to carry this information that you get from today's session to your communities. And 3, increase the pressure on hospitals to take action. And it means our hospitals where we go to receive care, but also hospitals where our families and friends are also receiving care. We need to all be aware of this issue. So yeah, with that said, I am really happy to introduce today's speakers, Anita Cameron, Brandy Seziak, Alan Cooper, and Fernando Taurus Gill to the stage. First, we're gonna go with Anita Cameron. We're really honored to have you here today. Anita Cameron is a disability rights activist who has been involved in social change activism and community organizing for 39 years, working tirelessly on the fronts of transportation, voting, LGBTQ plus rights, as well as disaster preparedness for disabled people. She's an incredible organizer who's been arrested 139 times with ADAPT during nonviolent civil disobedience as a form of protest. And she was and is part of ADAPT, many mayoral and governors advisory boards and committees for people with disabilities, American Association for People with Disabilities, and Not Dead Yet, from which care rationing work really comes from, as a member, as an organizer, and sometimes as a part of the board. So welcome, Anita. The stage is yours.
Good evening. Good evening, everyone. My name is Anita Cameron, and I am the Director of Minority Outreach for Not Dead Yet. And yes, I've been a member, and I served on the board from 2013 to 2017, and left the board to take my position as Director of Minority Outreach. I'm gonna talk a little bit about like what care rationing means, or medical rationing means, and basically it means restricting the access of some people to useful or potentially useful health services due to budgetary limitations. But that usually manifests itself as forms of ableism, ageism, and racism. We're seeing it in the COVID-19 has actually laid pretty bare racial disparities in healthcare and cases of medical rationing. The Office of Civil Rights has come out recently, with guidelines that say that you cannot discriminate against someone with a disability. You can't withhold medical treatment to someone based on their age or their disability, or stereotypes around their disability, or thoughts and biases around quality of life. And so that's kind of where we are now when we think of medical rationing, especially related to COVID-19. We think about the case of Michael Hickson, who was a 46-year-old Black man. He was from Texas, and he was a dad, the father of 5 kids. He was a quadriplegic. He had a heart attack, which resulted in brain injury and quadriplegia. And he was put in a nursing home where he contracted COVID-19. And, but due to his disability, the doctor decided not to treat him, specifically because of his disability, and specifically stating that he had no quality of life due to his disability. The doctor didn't think he had really any quality of life. So he was placed in hospice and basically allowed to die. He certainly, 2 things are clear. There was direct contravention of those Office of Civil Rights guidelines because of his disability, and he fell under Texas's futility laws, and that's a form of medical rationing. It really is. And Texas futility laws are the worst in the country. So some of the things, that Not Dead Yet, that we've been, looking, at doing or trying to combat this because we were involved in some of the settlements and bringing, along with Adaptive Texas and a few other disability organizations, bringing Mr. Hickson's case to the fore. So
listening to this thing, Alan Cooper.
Oftentimes in certainly futility cases, they're decided by an ethics board, hospital ethics boards, which, as far as I know, there are no record people with disabilities serving on those boards, either now or in the past. So one of the things that we're advising and looking at people, to do is to try to get on those boards. Another thing that we are advising is to get copies of your state triage policies, or the hospital triage policies, because it goes beyond COVID-19. So if you know, the state of Tennessee filed an Office of Civil Rights complaint, and they got this settlement, which is certainly better than most. One of the things that it suggests is that people's personal ventilators are not reallocated, because that's a big fear among folks with disabilities, that you go to a hospital in this COVID environment, and they decide that oh, you got your ventilator, well, you're kind of up in age, we're going to take this. They'll take it from you and they'll reallocate it, give it to someone else. Medical rationing, because it's ages. So it says, okay, if you're a certain age, if you're a senior, your life expectancy isn't going to be the greatest. Your quality of life, and all, it's ableist, because the assumption is that we, as people with disabilities, don't have a quality of life, or certainly don't have a good quality of life. And it's anti-poor, because often, especially with the utility laws, the ones that that come to the fore, that are all over the news, involve people who are on Medicaid. And also, every last one of the cases that have come to light involves Blacks and people of color. So another thing that we're, trying to do, obviously, is to get legislators to introduce or sponsor state laws that are consistent with this Tennessee settlement, because there's different states have different settlements. It's not across the board. You know what I mean? It's not uniform. And also get disability rights advocates on local hospital ethics committees. Hey, try to have a meeting, and if you can't have a meeting, we advise to keep trying to contact them, keep trying to have meetings, show up, at their meetings, just keep pushing and pushing until, they give up and say, hey, let's just deal with this and be on board. And so that's some of the things that Not Dead Yet is doing, that Not Dead Yet has suggested, and that we're doing. And unfortunately, as I said, it's the whole care rationing. It's really complex, and it definitely there's definitely ageism and racism and ableism and anti-poor sentiment and discrimination that swirls this around this. And we have to be vigilant. We have to be very, very watchful, keep an eye on these laws and whatnot. Unfortunately, I don't think Michael Hickson, I don't think he is the last case. You know, he is certainly, his case is certainly the tip of the iceberg, especially with so many people being placed into nursing and other congregate facilities full of folks who have COVID-19, and the efforts of some organizations and some CILs, Centers for Independent Living around the nation, who are working on things like emergency relocation of people from nursing homes to a safe location, and then hopefully into their own home or their, you know, with their families or something, not going back into those congregate settings. And so I'm gonna stop, you know, right here, because I can go on and on and on, unfortunately, but I'm gonna stop right here, and certainly welcome, you know, certainly more than happy to answer any questions you have.
Thank you so much, Anita. Thank you. Thank you for telling us to keep pushing. Yeah, on many levels, getting a disabled person and an older person and a disabled and an older person, right? To boards in our hospitals. Remembering Michael Hickson, honoring his life. And yeah, pushing for care rationing to not be implemented as a budgetary limitation, because we are not low on budget if we think about how much money is going into policing, right? All of this money is like, we can't reallocate this money. We can't find the money when we put our want into it, and we need to keep pushing for it, yes.
When this, Anita, the case with Michael Hickson, what was so frightening about his case was, although he was in Texas, and Texas, you know, was getting pretty bad with the COVID, they had not yet begun their medical triage protocols or anything like that. So it wasn't like, there should have been no reason why he was denied treatment other than the fact that he was disabled.
Exactly. Yeah, like the people use budget as an excuse when there's actually so much more than that, and ableism and racism, and yeah, and thank you also for bringing in nursing homes into this as well. Any questions from public? I just want to read Betty Trainor's comment in the chat, who says, very good recommendation from Anita Cameron, who is on the hospital ethics boards, and be sure at least one senior and one person with a disability, I'm assuming, is there. This is an action. Yeah, great. Okay, thank you. We're gonna go to Brandy. Brandy Senziak is a fat, legally blind, disability, and immigration attorney who supervises the legal department at Independent Living Resource Center, San Francisco. She is the directing attorney with the FAT Legal Advocacy Rights and Education Project and the supervising immigration attorney at Homeless Advocacy Project. Brandy also has a background in criminal defense. Welcome, Brandy.
Hi, thank you. Good afternoon, everyone. I'm going to walk through the California guidelines and for advocating. But before we talk about our rights and the ways we can advocate for our rights, I want to acknowledge as a white person that all of these encounters and the ability to advocate are shaped by racism and racial dynamics. These racial dynamics can come into play in lots of ways. For example, depending on your racial background and the attitudes of people that you encounter, insisting on your rights may be easier or harder. I want to remind everybody that nobody is disposable. Nobody is disposable. Everybody deserves equal access to these rights. We're all worth fighting for. On June 9th, 2020, the California Department of Public Health released its revised crisis care guidelines for COVID-19. These guidelines apply if and when there are so many critically ill COVID patients who need intensive care that there may not be enough staff and equipment to treat everyone. The recommended protocols include rules for deciding who gets prioritized for care when medical resources are scarce. Here are some important parts. Non-discrimination and reasonable modifications are emphasized. California's new guidelines emphasize equality and non-discrimination access for many populations. Healthcare decisions, including allocation of scarce resources, cannot be based on age, race, disability, including weight-related disabilities and chronic medical conditions, gender, sexual orientation, gender identity, ethnicity, including national origin and language spoken, ability to pay, weight, size, social economic status, insurance status, perceived self-worth, perceived quality of life, immigration status, incarceration status, homelessness, or any past or future use of resources. The guidelines direct healthcare providers to make reasonable modifications for older and disabled patients. These include modifications to COVID-19 visitor limitations, effective communication for people with disabilities, modifications to ensure equal treatment in triage and allocation decisions, like adjustments to triage scores. The guidelines direct hospitals to ensure that they have an appointed disability accommodation specialist with the responsibility and authority to ensure that needed accommodations are provided. The document also notes that healthcare providers have an obligation to provide interpreter services. The document reminds healthcare providers that during triage situations, facilities and providers are still subject to the federal and state anti-discrimination laws. No reallocation of personal ventilators. The guidelines make clear that personal ventilators used on a regular basis by disabled patients cannot be reallocated to other patients who are perceived to have a better chance to survive. Non-discriminatory triage. In its primary triage framework, the new California guidelines commit to a single principle of saving the most lives. The principle endorsed by the community advocates. Triage tiebreakers. In cases where there are insufficient scarce resources for every person in the same priority group of triage, the guidelines permit the guidelines permit clinicians to to assess whether any patient has a severe life-limiting condition likely to cause death in the near term. If after consideration of severe life-limiting conditions, a tiebreaker is still needed, the guidelines advise using a lottery as a non-discriminatory means for allocating scarce resources. So, what can we do if someone we love is being denied care? Before you go to the hospital, if you can, it may be helpful to review the hashtag Nobody is Disposable Know Your Rights toolkit and print out the California Crisis Care Guidelines so you can show staff their responsibilities under the guidelines. These guidelines are really long and they're relatively new, so it's possible that care providers will not know their responsibilities under the guidelines. You can try to make connections with staff who seem to care about you and ask for their help. Get them to see you as an individual and ask if they have any ideas of how you can get the care that you deserve. You can also ask to talk to a supervisor if you are not getting the care that you deserve. Remember that the staff, including the supervisors, will be under stress. They'll be really busy, so be direct and explain your situation. Depending on the circumstances, you can say things like, I want my best chance of survival. You could also say, I think I'm being denied care because of my age or my underlying disability or my race or my weight or whatever the characteristics are. You can also say, I know you're balancing a lot of people's needs, but my needs are just as important. Even though I'm an older or disabled or higher weight individual or any combination of those things, my needs are still important. If you still disagree with the supervisor's decision, you can ask for an ethics consultation. Most care facilities will have an ethics team involved in decisions about who is denied care or who is given limited care. Remember that people doing the ethics consults will also be under a great deal of stress and may be guarded because they are uncomfortable with the position that they're in. You can explain your situation to them like you explained your situation to the supervisor. You can also reach out for help. I know all of this information is a lot, and sometimes it can be very hard to advocate when we're feeling sick. So you can reach out to friends or family members or other support people. You can also reach out to legal organizations or private attorneys. You can reach out to the news media. Finally, if you are an individual with a disability, you may have the right to have a support person, a friend or family member with you at the hospital. Many hospitals have rules regarding no visitation during COVID. However, if you are an individual with a disability, you are entitled to have your support person with you in the hospital in order to ensure that you can access the hospital in the same ways non-disabled patients can. So you can find all this information in more detail in the Know Your Rights toolkit at nobodyisdisposable.org. Thank you for your time today, and if you have any questions, please feel free to contact me at brandy@ilrcsf.org.
Thank you so much, Brandy. Thank you for affirming that nobody is disposable. Yeah, and thank you for sharing the Know Your Rights toolkit that we pasted in the chat. There was a question from one of the participants, Susan Kitazawa. Wait, I lost it. Sorry, Zoom problems. There we go. The question is, would you elaborate on the July guidelines about the assignment of a disability specialist to a patient? Was this only in an inpatient settings or outpatient too? And is it just for patients being seen for COVID or for patients being seen for any diagnosis?
Hi, yes, thank you for your question. If I could, can we like copy and paste that question? I can follow up with the person later.
Yes.
Thank you.
So maybe we can connect you and Susan later. Yeah, if that's the easiest. Thank you. Yeah, so we've heard from Anita and we've heard from Bandy. I think now it's time, if that didn't get you pumped up, I don't know what would. So I hope that you're ready to take some action right now. I'm gonna paste our action document in the chat so everyone can see it and follow it as well. Folks who have access to chat and the link. I will also read out loud the actions that we have for the first part of our action taking session. So please contact your local hospital, hospital system, or American or California Hospital Association right now. We recommend you either trying to call. There are some numbers that I'm going to read out loud, and Twitter and Facebook. Probably social media is fastest right now. You can say, this is what happened to Michael Hickson. Can this happen at your hospital? And you can ask how they will make sure that health providers don't make treatment decisions based on perceived quality of life or perceived years of life remaining. And indirectly also based on race and ethnicity and income and weight and size and immigration status and all of that, right? Because all of that goes into that decision making. The phone numbers of California Hospital Association that you could call right now is 916-443-7401, 916-443-7401, and then Twitter is Cal Hospitals, like California, and Facebook is Cal Hospital with just one L. How should I'm gonna read out loud the hospitals that we have listed, and maybe folks can ask me for their @, for their Twitter accounts and stuff. We have the Twitter accounts and people of Kaiser, Sutter Health, and Dignity Health, SF General, and we're looking for information on UCSF, UCLA, UC Davis, and other local hospitals. So if you'd like to also put them into the document, feel free to do so too. So let's take 2 minutes. I'm gonna do so right now too. We have a question in chat. Repeat 2 minutes to do what? To send an email or to tweet out a tweet, or to post on Facebook, or to call the hospitals of your choice in the list in the chat, either California Hospital Association, Kaiser, Sutter Health, Dignity Health, SF General. We also have information of CPMC as well. If you don't finish right now, we'll have time at the end, but let's try right now. That's a great question, Bill. Why limit to hospitals? Why not include hospital foundations? Yes, anyone that you, like this is an issue that you need to repeat on multiple levels, right? Hospitals, hospital foundations, hospital board members, nursing homes, long-term care facilities, any local facilities. We have included the hospital names there, but feel free to reach out to any local facility that you think you need to check whether or not they're adhering to the guidelines issued by the state of California, or if they are discriminating against people. If you're living in a state that did not release guidelines that were not discriminating against people based on disability or age. Okay, so I think it's time for us to come back to our session, to our teach-in. We'll have a little bit more time to complete it. Okay. So now I want to welcome Dr. Alan Cooper, or Alan Cooper, more like. Alan Cooper is a self-described old guy at 78. He was on the faculty at Stanford School of Medicine for 38 years, serving as the chief of GI and hepatology for 5 years. His experience includes working for the Haight-Ashbury Clinic at the and time as an attending at the UCSF student-run clinic in MSC South Homeless Shelter. He served on the advisory council for the San Francisco Commission on Disability and Senior Services and on the San Francisco DEA's Community Health Advisory Council. Alan is a member of Senior and Disability Action and the Voluntary Services First Coalition. Welcome, Alan.
Thank you, Dawson. So what I'm going to try to do is give an overview of how care rationing actually works in practice, based first on the military brief experience where the colonel said, hey, 1 live private is worth 5 dead generals. Your job is to keep people alive, not who they are. Then later, with that in mind, when I became part of the liver transplant group, I learned about care rationing. At the outset in transplant, there were probably only half enough livers to transplant people who needed them. So a system of listing was set up, and to get on the list, you had to go through certain steps, which was really rationing. Even with that, between 20 and 30% of people who were listed didn't get a liver and died, which means that when you made a decision to list somebody, in some ways you were making a decision that somebody else would have to die. Thus, care rationing affects more than one person at a time. It's not just the person who you're putting in the ICU or not putting in the ICU. It's the person whose ventilator you may be taking away. I think the process for liver works reasonably well, and it has some similarities to the COVID guidelines, which are now, the California guidelines are now fortunately quite different from what they were originally and what the AMA guidelines are, because there are still things in there that allow discrimination. Firstly, it was always a group decision. There were usually once a week, 12 people met. Physicians, surgeons, social workers, case managers, and then a finance person to go over the case. Now, the physician surgeon had it pretty easy because all we did is say, this person will be able to survive the operation. And the surgeon said, yes, I can operate on them technically. The problems tended to almost always the problems came around psychosocial issues. because there was concern about once they got the organ, would they take care of it? And how you decide that is really hard. And so even in a group setting with everybody talking, we didn't always make the right decision. Let me be clear. I made mistakes, everybody made mistakes. For example, an easy one. Some hospitals preclude people from being listed if they're using any opiates for pain. Our program certainly didn't, but then we wouldn't transplant somebody who was in a methadone program until a friend who works in a methadone program referred someone to me and said, get them transplanted, they're wonderful. And they won't be a problem. And so we did. It took a lot of discussion, but it worked. Ethical. We had an ethicist, and the ethicist made it absolutely clear. Medical, physical, mental disabilities were not a reason for not transplanting. Even criminal history, and there was a famous case where a criminal got a heart transplant before someone else. It was in the papers, and there was some outrage, but it was right. That's what the ethicist told us, and that's the way we function. Finance. Whoops, scary. When a patient comes into the hospital, into the emergency room, the hospital owns that patient. And if they admit them, the hospital has to take care of them. And so we got a migrant worker. No resources, not a citizen. The hospital was hysterical. A transplant is worth hundreds of thousands of dollars to the hospital. And the administration was pushing, can we transfer them? Can we do this? And then finally I got a call one night, happened to be on, from the medical director, who is an administrator, not a member of the staff. And he said, look, I'm a doctor. I went to medical school. I took the oath. Transplant them and I'll take the heat. So financial considerations, while they're banned now, can be very subtle. And that's something we have to be really careful about. But once you go to the emergency room, the hospital owns you and they have to treat you the same as any wealthy person, no matter whether you can afford it or not. Then we got to age, and I'm going to give you some examples where age, I'm sure, was an issue, and where I was probably guilty also, because doctors always say, well, they're young, we got to do more. And that's a mindset. Let's be clear, it's a mindset, and you have to learn not to be ageist. And so one night, there was a young, very upper middle class person came in, a young woman, who had taken a Tylenol overdose, had liver failure, and needed an immediate transplant. Was it a suicide attempt, or maybe it was an accident? Well, there was reason to think it was an attempt, but the discussion was young, and she got transplanted. Within a year and a half, despite intense psychiatric care, she committed suicide again. We discriminated for age, and it was wrong. Later, I had an older patient, same circumstance, took an overdose, but this was older, not wealthy, a European immigrant, and they decided I was not to transplant. Well, she survived. And when she was awake and we could talk to her, it was an accidental overdose. She was getting a lot of pain pills for her back, didn't realize there was too much Tylenol. So age is the hardest thing to get out of your mindset. And for our group, SDA, and as an old guy, I worry about that. And that's where it came up later. The rule is someone over 70 can't get transplanted. And that's still the rule, because I looked it up today broadly. Now, you don't have to follow the rules. I had a couple of patients who were over 70 who I thought would survive the operation well. That was the concern. They got transplanted after much discussion and fighting and proving. And then others of my colleagues started bringing their older patients forward. And so we got sort of a reputation for transplanting old people. What was most gratifying is one of them was an African American who, after being transplanted, decided to spend his weekdays watching baseball and his weekends going to African American churches and clubs, advocating for more organ donors and for more people to look into transplant, because African Americans are significantly underrepresented both on the list and in the donors. So old people can do good. Some of us are trying. And as I said, still says 70 should be a cutoff. That's the Organ Donation Society. And one more, and this is where it gets even trickier, and this has been brought up, but ethnicity and culture can play a role. I had an American Indian, a Native American patient. She was poor. Her granddaughter took care of her. She was listed. Well, they didn't have a car. They missed a lot of appointments. They missed blood draws. The case manager, who was a very nice person, very sincere, but came from a very different background, whereas the Native American was more spiritual, believed in someone would take care of her, and this was these are the facts, these are the rules, we can't transplant you. And we fought. She got transplanted, did well. Her granddaughter finished college. They both moved back to the reservation, to their family. So that is a place which is subtle. More subtle is going to come up now with the guidelines, the current guidelines. There's something called a SOFA score, which the ICU uses to determine the prognosis. In the SOFA score is kidney function, respiratory function. In communities of color, there's more diabetes, there's more renal disease, there's more hypertension, renal disease because of it. There's more asthma, and they are going to have, just at the outset, worse SOFA scores. Well, too much reliance on the SOFA score, I think, is going to be bad. Why? Because in the early days of COVID, when 80% of the people and then 50% of the people in the ICU were dying, you really, more attention could be paid to selecting the person most likely to pull through. But now it's, according to the chief of medicine at UCSF the other day, they're down to a 25 to maybe 30% mortality rate in the ICU, which means that sicker and sicker patients are going to be able to survive. And we have to push that the SOFA score does not become the determinant. So what are my recommendations? The board has to be multidisciplinary. We've talked about that. Not just a bunch of white doctors, okay? But including other caretakers, including lay people, and particularly people from affected communities who have cultural sensitivity. No psychosocial or disability exclusions. It says none, but I'm a little worried about what's going to happen with the homeless, with substance abusers, people who are using perhaps heroin. They have a good prognosis eventually. They should not be excluded, although there may be prejudice. So there have to be people on that board who are sensitive to that. And then the whole group has to have the discretion in the end to violate the guidelines, especially if it will let them be broader, more community sensitive. So that's my advice from back in the day when I was on the war front. And I'm happy to take any questions.
Thank you so much, Alan. Yeah, thank you so much for that and for talking about how it actually works, the guidelines, how actually work in practice, and how the decisions are needing to be made and based on very superficial knowledge of people. And then that responsibility just carries on. It's really inhumane to just ask people to make decisions like that and move on from that, and also to direct our attention away from how these individual decisions are hiding the fact that the problem is that the liver costs like $10,000, like $100,000, right? Like those are the things that are a problem, that are limiting the access to this scarcity of resources mindset that we're replicating. Thank you so much for that. And I hope we have some questions for you as well. Yeah.
Oh, hi. Did you see there's a question in the chat? Is there training for triage team on new guidelines and other aspects Alan mentioned? That's from Betty Trainer.
I hope so. I think one thing is the people on the front line usually are trying really hard and try to keep up and do the right thing, particularly in the ICU, where they face these problems even before COVID. Beds were limiting occasionally, so that they are very sensitive to it usually. And all we can do is if you're in the situation where you bring a loved one to the hospital and they end up in the ICU, and there may be, or there's a question of should they go, that's when they're going to need advocacy, and you need to speak to the people in charge.
Thank you so very much. And I'm so glad that I made it in time to hear your presentation. I just was so blown away listening to you yesterday, so clearly, articulately state the case for why somebody shouldn't be able to judge somebody else's quality of life and the meaning that we all bring to this earth. And speaking of incredible meanings of things to this earth is the next speaker, if I can move on to the next speaker and we come back if there are more questions at the end of that. I want to introduce a colleague of mine who has such an incredible gift to this planet, as so many of us know people like this. Fernando Taurus Gill is our next speaker, and he's the director of the Center for Policy Research on Aging at the Luskin School of Public Affairs at the University of California, Los Angeles, go UCLA, woo woo, where he's a professor of social welfare and public policy. He's a leading spokesperson on demographics, aging, and public policy. In 2010, President Obama appointed him vice chair of the National Council on Disability during the Clinton administration. He was the first ever assistant secretary on aging in the US Department of Health and Human Services. And in 1978, President Carter named him to the Federal Council on Aging. He's a board member of AARP, a member of Academics of Public Administration, Gerontology, and Social Insurance. And he's the author of 6 books and more than 100 publications. And I am blessed to serve on the Master Plan for Aging Stakeholder Advisory Committee alongside him. And I hope that you will hear the beautiful case that he will for why it so matters that people don't have their care rationed. So without further ado, Fernando, where are you? There you are. Can you take it away?
Right here.
You are here. Yay, welcome. Oh, you just went on mute. Let's see, let's get you back off of mute.
Can you hear me? Yes, I'm still old school when it comes to technology, but in either event, thank you, Debbie, for your gracious invitation, for your friendship, but most importantly, for your advocacy. And it's a pleasure to be with all of you. I know I only have a few minutes since you have a crowded agenda, and Debbie and I just came from our advisory meeting with Secretary Galley and the other department heads as we address this pandemic and planning for an aging society. I thought maybe where I might be helpful is providing a little broader perspective, since my areas are within the policy and politics of issues like long-term care and healthcare policy, disability policy, and increasingly I address issues of diversity and immigration as it all comes together with an aging society. But I have been speaking more often, however, on issues of ageism and ableism and nativism and racism. I call it the coming together of the isms. And this pandemic has really highlighted certainly the structural defects in our country, the social, economic disparities, the racial disparities. But it also, I think, highlights that maybe we're not quite ready for the aging of a society with greater numbers of persons facing various types of disabilities. I thought I would provide kind of a three-part overview, the short, intermediate, and long-term implications of how ageism and ableism and the other isms come together. My own personal story, and Deborah knows it well, I kind of have this destiny where I fit three really cool categories. I'm a person with a disability, a polio survivor, having contracted polio at a very young age and spending most of my formative years at Shriners Hospital in San Francisco. And they did great things to give me a measure of independence and a wonderful career, family, and a good life. I got into the field of gerontology as a graduate student and have built my career in gerontology. That's the second category. And the third one, I'm a Latino. So I certainly represent, the growing ethnic diversity, the Asian Pacific, the Latino, the African American, the immigrant, the refugees, that's making up this state and will make up the rest of the country. And then lastly, in my field of advocacy on behalf of older persons, prior to the pandemic, most of the field of gerontology and the public involvement in aging had more to do with what we call the longevity dividend, purposeful aging and leisure and recreation and all the wonderful benefits of living a longer life, even living to 80, 90, and 100 years of age. The pandemic has altered that and given us a reality that not all is perfect in this aging and this longevity. And now in the pandemic, we realize that there is still a high amount of ageism and ableism, in a sense, discrimination on the basis of age and various levels of disability. And certainly we see the racism and the nativism. That is all represented by these debates we've had on how we ration care. And our advisory group, the master plan, pushed back against California's initial critical care standards, which would have determined scarce medical care based on various forms of age or disability. Other states, sadly, are using some version of these rationing, including Arizona, Texas, and Florida. And all of us have to push back against using age and disability. And that's kind of the short-term issues that we're facing, pushing against this discrimination. That's a short term. The second is the intermediate. And that's how we address the reality that certain populations are especially at risk in this pandemic, certainly those in skilled nursing facilities, those in congregate settings, those in institutional structures. In California, almost 50% of the fatalities have been persons in some institutional setting. And that's a tragedy. And we're seeing that across the country. And so we have lots of work to do to address the needs of those that are in these kind of vulnerable situations. And that's going to be for the remainder of this pandemic. And just today with Secretary Galley and his staff, we're talking about how we can better provide support to those institutional settings that are trying to protect those persons that are older and those persons with disabilities. The long term, and I want to end it with this, ultimately, I think for all of us, those in this webinar, in this meeting, those of us who care about older persons, persons with disability, and especially for the public at large that hopes to grow older and enjoy a longevity dividend, we now have to address, I think, two key areas. First is what I call the public narrative. And that is, how do we get across to the general public through social media, through the print media, through the public imagination, that we all have a stake in pushing back against rationing. We all have a stake in addressing these isms. Right now, the media makes it seem that it only matters to those that are in an ICU. It only matters to those in the SNF. It only matters to an older disabled adult who has contracted the virus. But in fact, it matters to all of us, young, middle-aged, and older, healthy, or maybe not as healthy. And so one of our big challenges in the next 3-4 years, certainly post-pandemic, is changing that public mindset to learn from this terrible crisis and this terrible tragedy that any of us can be at risk of these ageism, especially ageism and ableism. But the other part of this next 2 to 5 years is to step back and look at what got us in this predicament. And what has us in this predicament is the failures of our society, those disparities that I mentioned earlier. We've not invested in public health. We don't have universal health and long-term care. We've created such economic disparities that Blacks and Latinos and other low-income persons, the essential workers, are especially at risk of mortality and morbidities. We've created a system of providing services to at-risk elders where they're forced to go into skilled nursing facilities when, if we had done it better, they could have been in a community setting or at home with the proper services. So the longer term agenda in addressing rationing, ableism, and ageism, and the other isms in my opinion, is that we need to move towards a set of progressive policies to get this country to realize we're a broken country, and if we're going to all expect a good, long, healthy aging with the quality of life, we need to learn from this terrible pandemic and the consequences that have impacted certainly the populations that we care about. So with that, I'll just end and simply say that we have 3 levels: getting through the next few months and protecting those at risk, addressing the need to improve the long-term care and health needs of those that are facing illnesses and the virus and making sure we don't ration care for them. And then lastly, starting to build on this so that if we go through this pandemic again, hopefully we'll have a more robust, well-funded, compassionate system of health, long-term care, public health, so we're not in the mess that we're in today where we are even discussing rationing care. So I hope that's helpful and that gives a little bit of context to the critical work that you're doing. And thank you again very much for allowing me to say a few words on this.
Okay, don't go away because we have some questions for you, and that's it's how could you say anything that's not just amazing? I don't know. I have yet to see it, so I'm so glad that you got whatever care you needed to be where you are today, to be with us today, and to be teaching the next generation how they can be educated advocates. I absolutely love it. So Art asks, to make sure each of us going into a hospital has the best potential outcome, should everyone going into a hospital have an advocate, whether it's a family member or friend? Is there a case for there to be a new role that might be called a patient rights advocate who could follow any patient who needs it from beginning to end of their hospital stay?
Yeah, would you like me to respond to that?
Yes.
Oh, yeah, thank you for that question. And let me just add this. Through all these issues we're addressing, there's a level of personal responsibility and proactive planning. And what do I mean by that? And I'll take my case. I'm a polio survivor. I'm 72 years of age. I know that, heaven forbid, if I contract that virus, that COVID, I may well quickly be facing a very serious situation What I've done in the last 3 months with my wife and my family and a few close friends is planned ahead. And I've created my own letters of instruction to make sure folks know, should I have to go into an emergency ward, should I have to, excuse me, should I face an ICU, here's what I would want, here's what I would need, and here's what I don't want. Secondly, to build relationships with the hospital and other staff, and in this case, I'd probably be at Kaiser Sunset in Los Angeles, and with my primary care physician, so that they know how I would like them to advocate for me, as well as my advocates, which would certainly be my wife and family members, recognizing, by the way, that what makes that kind of difficult right now is that you can't bring in folks with you should you be in a hospital with this pandemic going on. But the point is, there's various ways we can plan ahead to ensure that there's some type of advocacy structure for all of us. And then lastly, and not to be morbid about it, end of life planning. End of life planning. I served on the Institute of Medicine's end of life committee, and it's part of the natural life cycle. So I would say, yes, we will all need an advocate, a patient advocate. The time to prepare for that is before anything should occur, so that we can take the responsibility to develop a plan, have a group of people that know what we want and don't want, know how it might be activated should we have to go into a hospital medical setting, and ensure you have all the other proper plans like medical health directives, et cetera, et cetera. So it's a longer response to the question, but it does bring out the importance of planning and being proactive, because it can happen to any of us at any time.
Thank you, Fernando. So I was reminded by Jessica that I didn't introduce myself. I just jumped in and hijacked. So hi, everybody. I'm Debbie Toth. I'm with Choice in Aging and part of the Care Rationing Coalition with Jessica and a number of other folks who are on. I think that our impetus, and this may have been stated earlier, but the impetus was when we saw these crisis care standards come out from the Department of Healthcare Services that were so ageist and ableist and racist that our minds were absolutely blown. And the highlighting for me, being able to hear Alan and Fernando really bring home what it is, what are those crisis care standards, how do they operate within a hospital setting, what are our rights, how do we think about those, how do we change the dialogue around what quality of life is, and how we experience quality of life in our lives, and how do we address all of these isms that are in the system, built into the system, like just so baked in that we don't even see it. So as an aging person, we can be ageist and not recognize that that's what we're being. I think there's such a richness in what we learned from both of you today and your experiences. And I want to just thank you so much for taking your time to help us on this teach and help us learn. And I also wanted to take this opportunity to ask that folks do something. So we're not just here learning. Yes, we are learning. Absolutely, we're learning, but we're not just learning, right? We're here because, as Fernando stated, we need to change the dialogue, and we need to change to progressive policies, and we need to change the thinking. And in order to do that, we have to hold the systems accountable to what our desires are, to having people take those isms out of what we're doing. So I'm hopeful that somebody, Raya, I'm not even sure that I'm saying your name right, so forgive me if I've got that wrong, can put in the chat. We have a call to action, and our call to action is that we want the hospitals and health systems to value our lives just as they would anybody else's lives, and we want them to commit to making the statement that they are going to follow the crisis care standards that our disability and aging advocates worked so hard to get changed through the Department of Public Health. So we want to, there's a whole No Body is Disposable coalition, and we can use hashtags from them. There's a ton of information about what you can ask, but what we want you to do, what you want you to do, what we all want to see happen is that nobody has their care rationed. And so contact your local hospital, hospital system, or the California Hospital Association to make sure that they have good protocols in place that do not discriminate against disabled people, seniors, fat people, and people of color. This is what happened to Michael Hickson. Can it happen at your hospital? Can it happen in your neighborhood? I don't know if you talked about this story, but it really, I don't know, it broke something inside of me to read that his wife and children were begging for him to get care, and a medical team determined that he wouldn't have a quality of life. This is what we're talking about today. So we're asking those hospitals if they will commit to not making treatment decisions based on perceived quality of life, perceived years of life remaining, and indirectly based on race and ethnicity. We have a statement that they can sign that you can send. You can send an email, you can make a phone call, you can tweet, you can post on Facebook, you can, however you do it. And I'm sure there are plenty of different methodologies that I don't know that you have a way to get through to them. There should be a link that you can include that is the hospital pledge that we're asking for those hospitals to sign on to, that they're not going to be doing that. And I want to just give a special shout out to all of our disability rights attorneys who have been working so hard to make it possible for us to have this ask and to have the California standards be what they are today. Because as Fernando mentioned, we were pushing it from the Master Plan for Aging Stakeholder Advisory Committee to the Secretary of Health and Human Services saying this is a problem. But it took the attorneys coming together to be able to craft something that wasn't ageist and ableist and racist on its face. So all of these things coming together takes a village. And our village is creating some good stuff right now, but we're not done. We have a lot more work to do. We still have the issue of where the people that we're talking about are dying right now in skilled nursing facilities. They're dying in skilled nursing facilities because we have a poverty pipeline and because of all the isms that were highlighted by Alan and Fernando. And because we don't pay livable wages to the care workers and they have to work at more than one facility. And so if they get COVID, they're transferring it to multiple places where low income people are, who are aging, who have disabilities, and who are of varied races, right? It's disproportionately impacting all of these populations because our system is broken. So we need to stay grounded in that and not forget that we've got that going on too. Like, I think that this magnifying glass has exposed so many things, but I do want to focus that our ask today is to get those hospitals and health systems to commit to not making care rationing decisions based on those isms. So I don't know if I'm missing anything, maybe a wrap up from what happened earlier on in the meeting that I am going to watch later because it's being recorded.
Thank you, and thank you everyone. Thank you to our speakers again, to Anita, to Brandy, to Alan and Fernando. And what Fernando you have talked about really does uplift what all of our speakers have said, and kind of really, I think the whole really uniting thread is this self-advocacy piece, and how to advocate for yourself, as Debbie says, you need a village in a way. We need to stand for each other, and we cannot, it's much more difficult to advocate when you're just on your own, right? So sharing knowledge of how to do it, like simple questions we had in the chat of what should I ask and how should I get the commitment, right? Sharing those kind of bits of knowledge. You can ask for, this is what happened to Michael Hickson. Is that what's going to happen at our hospital as well? Can you make a commitment to not discriminate based on age and disability and race? Those kind of questions. We need to keep having a conversation with each other. We need to bring this conversation to our communities outside of this teaching as well. And let's keep talking about it and make sure that people don't die because of lack of care, because of some arbitrary reason that is used, such as finance or disability or age or any other kind of arbitrary discriminatory factor that people use as basis of their judgment. So yeah, thank you so much. And let's try to get in one more action. We really value not only talking about it, but also doing things, right, as Debbie said again. So I'm gonna post the document that we have, the call to actions document, into our chat once more. And I think we had one person who raised the hand. So we're gonna take our action. I'm gonna take the question and we'll be good. So please tweet, retweet our tweet on Twitter, our, what's it called? I don't use Twitter, so the address, not at.
Handle,
like
handle, your handle on Twitter.
Is S as in senior, D as in disability, _action. So please retweet our tweets and yeah, please engage with your hospitals and nursing facilities and long-term care facilities on social media, if you have social media. If you don't, please call. And we have found that they do work, so. Okay. And it's a great way for us to honor the ADA, which was, ADA 30 was this weekend, 30 years anniversary. So let's take 4 minutes to do that. I'm gonna take the question from the phone number ending with 9121.
Hello.
Hello.
Hello. Yeah, this is Eric. I just called because I wanted to know what Dr. Taurus Gill was saying. He said 50% of fatalities were in congregate settings. He just meant from COVID, right? Or did he mean total?
Fernando, would you like
need
to
to
answer?
unmute. Yeah, there.
Oh, there it is. Yeah, it's actually, and please correct me, Debbie, but it's for those that are passing away from the COVID in SNFs and congregate sites, roughly 46% of the total number that have passed away in California due to COVID have been those in those kind of facilities. Deborah, does that sound about right?
That's exactly what was reported in the San Francisco Chronicle. It's 46% across residential care facilities for the elderly, and that includes the boarding cares and assisted living facilities and the skilled nursing facilities. So that's
Thanks a lot.
Secretary Galley actually validated that figure.
Yeah.
Thanks. That's what I thought, but I wanted to be sure I was unclear from what I heard. Thank you.
Thank you for that question. We have one more question from Judith. Judith, would you like to unmute yourself? Yes.
Yeah, I just did that. I wanted to know if there was a place where the names of people who have died because they were refused, because their quality of life was not worthy of life. If there's some place where those names are being kept or stored and their stories.
That is a really good question, and and this, I'm guessing on this. If somebody else knows the answer, please unmute yourself and speak. But I think that we don't hear about these cases. Yeah. I think that it takes a family member who is elevating their voice, that is bringing the media to the moment, that allows us to learn that this is happening, because I don't think that hospitals are advertising that they're making decisions about their patients' quality of lives and pulling treatment as a result of that. So I think that it's really the folks elevating it, like William Bennett III's sister, who came to us, who was standing outside of that care facility in Vallejo every single day after he died at 32 years old, who was not COVID positive when he went in there, and got it from somebody coming into his facility. And she was a one-woman show. Her name is Shawnee, who was just bringing her daughter too, her 7-year-old kid with her, to just try and elevate this. I don't think that it's something we hear about. So I don't know that that list would be differentiated in that way. And I don't know how we would find out more about it. And I don't know if Brandy is on and has any answers that we don't have, but yeah, it is an under the radar injustice, is how I would say.
Yeah. What was the name of the person you just mentioned? Because I had never heard that story. I want to Google it and find out more.
So William Bennett III was the name of the gentleman who passed away with COVID, and his sister is Shawnee.
Okay.
And we did a vigil, and it's probably on sdaction.org. It's probably on their website. You can probably find, we did I don't know, it was a 2-hour, it was a long action, but we did a vigil for him. And part of it was held in Southern California in front of the owner of that particular skilled nursing facility's home. Mm-hmm. And the vigil was down there. And then we went up here in Vallejo to that care facility to provide care packages to the workers at that facility and provide them love and support, and also elevate the issues of underpayment of staff and lack of PPE and all of these other things that are contributing to the deaths of the people who are impacted by isms and living in those facilities. So.
Okay, thank you. Thank you. This happened to our friend in 2017, so it was pre-COVID, but it was definitely a case where his disability made it seem to the powers that be that treatment was not warranted.
Right. Yeah.
So
thank you very much. Yeah, thank you very much, Judith, for sharing the story and also for uplifting Frank's name. And yeah, thank you. And I think that also story highlights that this is not just a COVID issue, and how COVID keeps highlighting the issues that that we have been fostering for a time, if not centuries, right? And
exactly, yeah.
So I hope people have taken some actions. Please tell us in the chat if you have. And as you can tell, this is not just one action or 2 action kind of thing. It's something that we need to keep doing. And not only putting pressures on hospitals, we're focusing on hospitals right now, but we have put pressures on nursing homes, and we're going to continue doing that too. You cannot forget other long-term care facilities, skilled nursing facilities, but also detention centers, jails, and prisons, where disabled people of color are usually warehoused and do not get healthcare from there, right? So it's not just doctors at hospitals, but doctors in all of those congregate living facilities. So this is not just one-time issue. We're gonna have to keep advocating for it. And thank you for being here and for caring about this. And let's keep caring about it. If you want to get involved, if you're really passionate about it, visit our website, sdaction.org. You can become part of a membership and also engage in our campaigns. Yeah, we're always happy to have more people who are passionate about bringing justice. So.
And then can this be seen later by someone who hasn't, is it being recorded so it'll be available like on YouTube or Facebook or whatever?
Yes, I believe it's live on Facebook right now. We'll have to repost the video once the live is open, is over, sorry, it's over, and it'll be available.
Okay, great.
Yeah, okay. If any of the speakers have any last comments, I think this is a great time. So
keep up the great work.
Thank you.
Thank you for listening. And I hope I spoke loud enough.
Yes, Alan.
This is Anita Cameron. Thank you for having me. And thank you everyone for the work that you're doing to combat this. Thank you very much. And thank you for having me.
Thank you, Anita.
Thank you everyone for listening, and remember to keep fighting, and nobody is disposable.
Thank you, Randy. Okay, thank you. I want to thank our interpreters, Mark and Chris. I want to thank our captioner, And everyone who helped to bring this together, our participants, you're all really lovely, and Debbie for co-emceeing. Yeah, thank you, and I hope you have a good rest of your day. Bye.
Thank you. Bye.